What criteria do you use to determine when a patient may benefit from microgram dosing versus typical 1.5 to 4.5 milligram LDN protocols?
I think it's based on all of our experience, as you've heard us talk, but you can generalize it a little bit. If it's a patient with an underlying autoimmune condition, especially with Hashimoto's, we start pretty low. I will start with 0.5 in those cases, sometimes even 0.1. We're looking for the immune system, rebounding, especially, and if you've got any patient with an underlying infection, like they've got rip-roaring yeast, they've got Lyme disease, they've got viral reactivations, you're going to have to start really slowly, or in my opinion, if you have something that's really scratching at the immune system, treat it first. If I have a patient with rip-roaring yeast, I always treat it. I tamp that stuff down, and then I will start the naltrexone. Other patients who maybe have a history of opioid use, strong alcohol use, other things, and a pain, and who are not on those drugs now, but then have a strong pain component and it's very inflamed, we may start higher. Dr. Paul Anderson also, I'm not so brave as he is. I don't do his reverse protocol, the European reverse protocol so much, but sometimes they will really try to tamp down the inflammation by doing 6 or 9 or 10 milligrams of naltrexone first and then bring them down. I tend to bring them up, or I'll use smaller doses and will go to BID, or like Dr. Kim, who will microdose and then do it several times a day to find that maximum effective dose.
So it's a little bit different. For me, pediatrics, I always start 1 microgram, and then they take 2, 3, 4, and then I double that. So if it's a combination of arithmetic and geometric sequence, so in 3 months, you get caught up to 100 microgram, 200 microgram, 300, 400, and then from there, you can go to milligram dosing. So I just tell them, and the history is really important if you assess people's endorphin reserve. If they're functioning normally, they're sleeping, and then in the morning they have energy, and at the end of the day, they have energy to do things, their endorphin reserve is probably normal. Those people, you can start at 500 microgram or 0.5 milligram, no problem. It's the other people who have had fibromyalgia for, let's say, 10 years, chronic fatigue syndrome for maybe about the same, or chronic pain for about 5 years. I can guarantee that endorphin reserve is going to be a problem. So in those people, how sensitive are you to medication? And they say, I'm not sensitive at all. Then I say, let's start at 100 microgram. So you know what, I'm very sensitive. And then I'll say, okay, you have a choice. We can start 1 microgram, 10 microgram. And I kind of leave it up to them. Usually they have a very good sense of who they are. And the other thing is that you can teach. What I do is that there are videos of cereal dilution, so I share it with them. And then there are products out there that's 1 milliliter in 100 ml that's built in. So if you do that dilution, it's 10 to the minus 2, and then the next time cereal is 10 to the minus 4, and then you do it again, 10 to the minus 6. Now, I don't tell them to do that unless they can't afford it. One exception is if they're ultra sensitive. They won't make it less than 1 microgram, I don't think, compounding wise. So,
you can, it's different.
Yeah, and then they can't test it. So what I tell them is get the 1 microgram, try it. If you get side effects, then it's 10 to the minus 6, and then you do the 1 to 100 dilution, now 10 to the minus 8, 10, and then 12. At that point, you're really in picogram range. And if they don't tolerate that, I tell them just back off. Let's circle around it. Like she says, use another tool. My favorite is actually methylene blue. When they have symptoms like MCAS triggered symptoms, methylene blue can be very helpful to calm that down.